Biological need operates on a scale approaching infinity. Human bodies degrade, mutate, and succumb to injury, generating medical demands that multiply day after day. But the resources to meet that demand, doctors, surgical suites, sterile bandages, raw chemical compounds, exist in strictly finite physical quantities. This is the axiom of scarcity. To see this collision in real time, you only need to observe the emergency department of a major public facility like Burr Hospital. During a seasonal dengue outbreak, the patient influx spikes dramatically. However, the exact number of intensive care beds inside the hospital remains fixed. The physical architecture cannot expand to accommodate the biological reality. Because of this strict ceiling on capacity, doctors are forced to act as economic administrators. They must abandon the clinical ideal of treating every sick person and instead ration their care based on strict triage urgency. Managing a disparity this severe requires viewing healthcare through a different lens. It is a rigid economic system governed by mathematical constraints. To maximize survival, we track the flow of resources between three nodes: budget pools, clinical facilities, and patient populations. Nepal provides the optimal testing environment, with a network stretching from dense urban centers into isolated mountainous terrain. To solve the macro problem of public health across an entire nation, we must first master the microeconomic laws governing how a single rupee is spent. The foundational law of healthcare economics is opportunity cost. The true price of any medical investment is always the exact value of the next best alternative that you gave up to make it. This progress bar represents a provincial health budget. Administrators receive a fixed pool of capital and choose exactly where it flows. If they allocate this entire budget to a single CT scanner for the urban hospital, the capital is immediately exhausted. The direct consequence is stark. 20 distinct rural health outposts are now left unstocked of basic essential medicines. In a zero-sum budget environment, every rupee spent on one patient's intervention is a rupee actively denied to another patient. Mature health systems do not evaluate funding choices in black and white. They measure value at the margin, evaluating the precise return on the very edge of an investment. Consider a single dose of the polio vaccine administered to a child in the remote district of Manang. We map this using marginal benefit. This coordinate plane tracks the exact amount of additional health improvement gained by adding exactly one more unit of a service. Plotting this first unit of care on our graph registers a massive immediate spike. That single intervention guarantees lifelong immunity and immense survival value. But the law of diminishing marginal utility guarantees that value degrades over time. By the time a healthy patient receives their 10th routine checkup, the new health data generated is nearly zero. The curve flattens completely. We see this clinically as well. The first tablet of paracetamol breaks a fever. By the 5th tablet, therapeutic benefit is gone, toxicity risks begin, and the curve drops into negative territory. This must be weighed against marginal cost. Once a hospital laboratory has purchased the expensive machinery, the cost to run exactly one extra blood test is minuscule, just chemical reagents and a few minutes of technician time. Administrators stretch their capital by funding services strictly up to the point where the marginal benefit drops below the marginal cost. Any spending past that point is mathematical waste. Patient metrics dictate individual treatment, but entire populations are driven by the macroeconomic forces of supply and demand. Healthcare supply clusters where the financial incentives are highest. In Kathmandu, dense networks of private clinics and pharmacies provide services precisely because the urban market allows them to charge higher consultation fees. Demand responds inversely to cost. When the government introduced the AMA program to make maternity services completely free, the sudden removal of the financial barrier caused an instantaneous, massive surge in patients seeking institutional deliveries. This graph illustrates market equilibrium. In scenarios like private PCR testing in Pokhara, the market eventually stabilizes at a central point. The price settles exactly where a clinic's operational costs match what patients are willing to pay. But healthcare markets contain a critical anomaly that breaks this equilibrium: the elasticity of demand. Elective procedures like teeth whitening have elastic demand. If a clinic raises the price even slightly, the quantity of patients willing to pay drops off a cliff. A life-or-death emergency appendectomy is profoundly different. The demand is completely vertical or inelastic. A patient facing death will pay whatever price is demanded, regardless of how high it goes. Because acute survival is strictly inelastic, pure free markets will naturally extract all wealth from dying patients. Structural policy interventions are required to prevent systemic exploitation. To counteract those market failures while navigating extreme scarcity, a health system must optimize for distinct pillars of efficiency. The first is technical efficiency, generating the absolute maximum medical output using the absolute minimum inputs of staff, time, and supplies. Tilganga Eye Hospital demonstrates this in practice. By utilizing highly specialized assembly line surgical techniques, they can process 50 cataract surgeries using only 5 nurses, severely outperforming standard resource ratios. But output alone is useless if the wrong treatments are provided. This scale measures allocative efficiency, the philosophy of distributing resources to produce the specific mix of interventions most valued by society. Funding high-end organ transplants saves a handful of individual lives, but routing those same funds into broad primary healthcare, vaccines, maternal nutrition, and sanitation creates a mathematically superior return in total societal health. Nepal's strategic prioritization of thousands of scattered primary care outposts over a few central mega-hospitals is a direct application of allocative efficiency. Technical efficiency guarantees the machine runs fast. Allocative efficiency guarantees the machine is driving in the right direction. These targets lead to a final, theoretical economic standard, Pareto efficiency. A system reaches a Pareto-efficient state when it is perfectly balanced, meaning it is mathematically impossible to make one person better off without actively harming someone else. Imagine a closed system. A remote clinic possesses exactly 10 vials of anti-rabies vaccine. Outside, there are exactly 10 patients who have just been bitten by feral dogs. If the administrator allocates 1 vial to each bitten patient, survival is guaranteed across the board. The allocation is perfect. If we attempt to alter this and give one of those vaccines to a healthy person requesting precautionary immunity, we instantly inflict fatal harm on one of the dog bite victims. The system cannot be optimized further. Human biology is messy, and true Pareto efficiency is almost impossible to achieve in large populations, but it serves as the ultimate diagnostic test for evaluating any new health policy. Look at the fully constructed model. Budgets, clinical outputs, and patient populations are permanently bound together by these rules. The constraints never lift. There will never be enough medical resources to meet the infinite demands of human biology. Because of this stark reality, every single administrative action taken must be ruthlessly weighed against its exact opportunity cost. By tracking diminishing returns, administrators know exactly when to cut off redundant treatments for the wealthy, freeing up the capital required to keep critical patients alive. By forcing hospitals to operate with strict technical and allocative efficiency, the system mathematically cheats scarcity, artificially expanding capacity from limited inputs. Applying rigid economic logic to human suffering is not administrative callousness. It is the only reliable mechanism we have for extracting the maximum amount of human life from an inherently limited world.